Okay, related to physical assessment of a preoperative patient, that is a key thing of the admission workup. When the patient comes in, we want to make sure that we have an accurate height and weight so that dosages of medications, in particular for anesthesia, can be given accurately. Vital signs, we want baselines so that we know that there's not a fever going on already, or some other critical vital sign that might need to be addressed, but also to really get that baseline of what is normal for that patient. Obviously, if the patient has had some type of accident that has precipitated the need for surgery, you can anticipate the blood pressure and the heart rate to potentially be elevated above what their normal would be. You'll always see a system assessment done by the physician and a history and physical that has either been dictated in advance of the procedure that they've done from the office and then is sent over for the case, or it may be the day of surgery. And you must include an assessment of pain, just like you would do for an admission that includes all the elements of pain assessment. And that way we kind of have a baseline for that as well. The systems assessment, this is usually one that nursing does some of this as well, but a formal one is done by the physician or the surgeon that is conducting the case. The anesthesiologist may do some of their own review of this or discuss in their notes the review, comparative to what the previous history and physical assessment was done by the surgeon, just to make sure right before surgery that it's similar and that nothing has changed since the last one. Of course, patients will have preoperative lab work. One of the key things that you want to know is they're going to have a type and screen, which is a draw of blood to evaluate their blood type and the presence of any antibodies. And sometimes if it's a procedure that they know will have lots of bleeding, they may go ahead and do a type and cross match, which gives them the ability to know exactly what kind of blood to go ahead and give. And sometimes they'll have so many units held of packed red blood cells to be available so that they can pull those to give those from the blood bank during the case. Other lab work that you often are going to see is, of course, what do we want to know if we're going to have bleeding? We definitely want to have a CBC and likely minimally a BMP, just so that we know the electrolyte levels, how hydrated the patient is, and we have clearly a good idea of hematocrit and hemoglobin. Some of our elderly patients will be on blood thinners, and those are often stopped before surgery, so they may have coagulation studies done just to see how that looks prior to surgery. Sometimes prior to surgery, you're going to see x-rays, different areas that might have been scanned so that they have a good idea of the location of the area that they're going to be doing surgery. That's very common for orthopedic surgeries, as well as surgeries that involve removal of tumors. Patient teaching, you really want to try to do as much of that up front as you can. A good example of when that's really, really necessary is when there's going to be significant rehab, such as with a total joint replacement. Many patients, after having that procedure, don't want to get up and move, and it is key that day 1 or 2, depending on the severity of the procedure, that they are up and moving. And so providing them that knowledge right up front is often helpful in trying to get them to cooperate with that when they get back to the room after surgery, and it's been that day after surgery. It's then better to remind them, now you know that this is part of what you had to do. We talked about this before surgery, sometimes that helps coach them along a little better. These are just typical other physical preparations that the nurse is generally responsible for. Of course, you want to ensure that the patient has a good working intravenous line. Size may be of importance. If you're going to have a surgery where there's heavy bleeding, a larger bore angiocath needle, like an 18 gauge and a very large vessel might be needed. Also, if the procedure has to be done with any kind of contrast dye being used like under fluoroscopy or something, so they can see where they're going to do the procedure. Sometimes they may want one that's at the antecubital level or higher in the arm, because that way they can ensure that it's more likely to be able to infuse the dye. Sometimes you may have one that's in, and when your patient goes down for surgery and comes back, they come back with much larger IV sites, and often they will make sure that they have 2 IV sites in a lot of agencies, so that post-operative, if one isn't working well, they have a secondary site to use during the case as well as when you get them back on the floor. Bowel and bladder preparation. Some cases, the bowel and the bowel may need to be evacuated, so you may have to give enemas or preps the night before to kind of clean out their bowel. Bladder may need to have void before they go if it's a short surgery. Sometimes they're going to put a Foley catheter in somebody during the case for accurate output. And skin preps, you often see patients have to get chlorhexidine skin baths of the affected site might be ordered prior to surgery. If it is an area that there's hair on in the area, they have found that you no longer shave those areas, but that you clip the hair as close to the skin as you can, because shaving irritates the skin and is much more likely to cause a post-op infection. Medications, timing is real key. Some preoperative medications have to be within an hour of the actual incision, and so depending on how long they're going to have the patient down in a holding room down outside the OR before the actual incision is done, in some agencies those preoperative meds may be given in that area versus on the floor before they go down. You're going to always make sure you've got assigned consents on the chart, the history and physicals complete, and other items, things like, are they in a hospital gown? Do they really have all their clothes off underneath that gown in terms of underclothes? Do they have dentures or glasses or valuables or money or anything that needs to be locked up and safeguarded while they're off the floor? All those things need to be removed. Even artificial things that might be part of their body, like some people may have like a dental plate that's kind of in there but can be taken out that you don't even notice. Obviously that could be in the way of somebody's being intubated. So really kind of checking out anything that's not attached to them needs to be taken off. And most of the time, unless they're on a really important IV drip of some sort that has to be maintained consistently, a lot of times that you will just saline lock off their IV for the actual transportation downstairs to wherever the OR suite is. And then, just really validating, do you have phone numbers and things for families, for contact? And then, really reporting off all of your detailed information to the person that's going to be taking them down. This is just a slide that talks again a little bit about skin prep. Again, these are some of your key nursing diagnoses. We've already talked a little bit about fear and anxiety. Knowledge deficit is key in terms of educating, but also actions related to that often also help the fear and anxiety. Sometimes patients may need a mild sedative such as, Ativan or another type of med that might help them be a little calmer prior to surgery. Again, we're going to be doing assessments, trying to look at the patient to see what other actions can alleviate fear, anxiety, and knowledge deficit, actions that are going to be preoperatively done to prepare them for the case. Now, in terms of intraoperative patient, I'll try to get through some of this. This is kind of what your typical OR suite looks like. You have a couple of Mayo stands in there where your sterile equipment is situated within reach of the surgeon. Each physician may have like a checklist for a particular case as to what types of every piece of equipment and every supply that he may need for a case. They are very, very organized like that down in the OR, to where they may have those all pre-packaged, just totally ready to go for Dr. Jones. And so, getting ready for a case can be opening up some of the equipment, turning on some of the machine and equipment for monitoring and preparing the patient in that way. But and of course all of the scrubbing and things that we're going to see in a minute. On the right, that picture is basically an anesthesia machine. Just wanted you to kind of see what that looks like and what the anesthesiologist or the certified registered nurse anesthetist might be manning and monitoring. They're kind of responsible for really the one who observes all the vital signs and pays very close attention to all that during the case. So you do have inpatient surgical settings, which we're talking mostly about, but there are also ambulatory or outpatient surgery where someone comes in, has a minor procedure, rest in a post anesthesia kind of care area for a few hours, and then is helped to go home with the family or with somebody with them to drive them. So, you do have elective surgery, which is something that people can either have or not have, but they think it's something that might help them, but it's not really urgent or anything. A good example of elective surgery might be a joint replacement. It's not urgent, not emergent, but they've got a wearing down joint and they want to replace it. Another elective surgery might be bariatric surgery. While I need to lose weight and be healthier, I can choose to have the bariatric surgery or not choose, or elect to have it or not. Urgent surgery is something that the person has a problem for that is really needing addressed. It's maybe something that doesn't have to be done in the next 24 hours, but it needs to be taken care of soon. There are lots of conditions like that are problematic. Someone may have a tumor growing on their intestine, and it is urgent that needs to get removed, but unless it's at the point of breaking the wall through of the intestine, it may be something that's not deemed emergent. And then emergent surgery is when, let's say somebody comes in and they've got a heart attack going on, and they do, the typical cardiac cath test, and they find that there's a complete blockage of two different coronary arteries. Then to keep their heart functioning, they've got to go emergently and have heart surgery, open heart surgery. So some things are going to be in all those different categories, so just trying to make sure you know how to identify the differences there. These are your sterile members on the team. The surgeon, of course, you've seen that on TV, I'm sure, on many shows where people do surgery. There are surgical assistants that assist the physician, and those are folks that usually help with, holding things, handing things. Scrub nurse. You may have a surgical technologist that runs a piece of equipment, or an OR technician that's in there to handle some type of technical